Hello, welcome to today's Op Talk on Kids and COVID-19. I'm Brian Bergstein, Deputy Opinion Editor of the Boston Globe. Op Talks is a recurring program in Globe Opinion where we discuss timely ideas with the authors of op-eds and other newsmakers. And today, we're grateful to have on with Sandra Fenwick, who is CEO of Boston Children's Hospital. So Children's is one of the world's preeminent pediatric hospitals. In addition to providing medical care for kids, it's a leading research center. It's the pediatric teaching hospital for Harvard Medical School. And Sandy has been one of the top executives at Children's for over 20 years. She's been CEO for the past 7 years. So, Sandy, thank you for being here. And before we get going, I just want to note our conversation is going to be shaped by some of the great questions that we've already gotten from readers. So those of you who have sent some in, thank you. And your ideas and your questions will shape the discussion to a great extent. But you can also use the Q&A function in Zoom in this webinar to pose a question. And in about half an hour, near the end of the talk, we will take up a few of those questions. So Sandy, there's a lot to talk about. Let's get into it. And, you know, today we're going to talk about the state of medical knowledge around kids and the coronavirus, both how the virus affects them if unfortunately they contract it, but also how their mental health is affected by everything going on around the pandemic, social distancing and quarantines and so on. But first, I was hoping that you could set the stage for us a little bit. You know, back when the outbreak began in the US over the winter, there was a lot of justifiable concern about the readiness of major ICUs and big hospitals like Mass General. But, you know, obviously Children's, even though there wasn't this huge influx of children getting the virus, Children's Hospital had to adjust in a big way. So if you could set the stage, tell us how this whole episode has played out at Children's, how you adjusted as March and April, went on into the spring, and what you've learned along the way.
Sure. Thank you. Well, first of all, thank you for the opportunity, Brian, to have this conversation. You know, back in January, we began to follow the guidance of CDC, set up our command center, our incident command center with our senior leaders and infection control and physician nursing and our emergency management team to really prepare. So it goes all the way back to literally the first month of this year. So we've been at this now for 7 months. What drove every one of our decisions and everything was safety. We say it 3 times, safety, 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 for how we prepared and how we now have it as our North Star for every decision we make. And so what we did around testing and our own drive-through center for our families and for our staff, PPE, screening, everything that on the adult side, they had to stand up very quickly in preparation. We had to do the same thing. We also sent 9,000 of our people home to work from home to protect them. And in fact, to be able to continue to work, but do it in hopefully a safe environment. We flipped to virtual care. We were typically doing about 14,000 visits a week at Children's, and we ended up with only about 1,000 in person as we shut down our clinics to protect our patients and families and staff. But we then flipped to virtual visits, doing over 2,000 a day. Which became, 80 to 90% of how we were delivering care, connecting with our patients and families, excuse me, and how we were then also making sure that, excuse me, their care was being continued to be monitored. Just a huge shout out to our adult colleagues who also were, really truly dealing with the surge. We basically said we will be a pediatric coordinating center for children as the adults needed to prepare for their own surge. So many of the hospitals shut down their pediatric ICUs, their inpatient units, and we took their patients so that they can convert those to caring for adults. We then said, as soon as you're ready to open, the patients go back to you. So that was one of the roles. We ended up sending critical care staff, respiratory therapists, and ventilators to our adult colleagues. And so there were many things that we did to participate and support our colleagues, but also, given that children were a little bit less impacted, we were able to, to really help out that way. We also had a number of our wonderful colleagues conduct calls. Dr. Jeff Burns set up a worldwide collaboration call that actually hosted 2,000 people in any given call for months. The CDC, the WHO participated, the European Commission participated, and it became sort of a learning environment that was hosted by Boston Children's. Dr. Randolph was tapped by the CDC to begin a study relatively early on the impact of COVID in children. And Dr. Ofer Levy, who runs our precision vaccine program, was tapped by the NIH to specifically focus, given the lesser impact on children, in this case, to try and pivot and work on adults and on the elderly. So a lot of different ways that we were impacted, and continue now as we ramp up and emerge to learn from all of the things we learned about how to protect, first and foremost, our patients, our families, and our staff.
So we want to talk about how kids are being affected in two ways. One is physically how they're affected if they get the virus, but also more broadly, we want to talk about their mental health. And let's drill down onto this question of how the virus can affect them physically. So on May 19th, you wrote an op-ed in the Globe that described this, new evidence that was emerging around multi-system inflammatory disease. And, many people in our audience are probably aware of this. It's been compared to Kawasaki disease, which is a childhood illness that causes inflammation of the blood vessels. At the time you wrote that piece, you mentioned that fortunately, incidents of this were rare, but those of us who are parents, I think our hearts sank around that time because we had been giving thanks for the first few months of the pandemic that, okay, at least this is horrible, but at least it seems to be sparing kids. Then we felt like, oh no. And in fact, the notion that it was sparing kids was so prominent that when schools first shut down, there was a lot of discussion about the public health value of doing that. By May, when you wrote that piece, things had really changed and there was a lot of fear. Can you update us on what we know now that we didn't know when you wrote that piece? What has the research shown about the prevalence of that inflammatory problem? How often are kids recovering? And, how much is it essentially, a big problem?
So you're absolutely right that kids have been somewhat spared in this. Most of them are not hospitalized. 1% of the hospitalizations are kids who have been hospitalized compared to adults where, it's a much, much greater issue. And most of the kids who have had challenges with COVID-19 have had underlying disease. So they've had asthma, heart disease, immunologic deficiencies, et cetera. This is interesting. This new syndrome, multi-system inflammatory disease or syndrome in children, clearly needs a lot more study. But one of the things we do know, 70% of those kids are actually healthy. Unlike the kids who've been hospitalized, 70% of the kids have no underlying disease that we can detect. They present with fever, inflammation, GI symptoms, and at least one organ system, if not more than one organ system, is affected. 80% of the kids who present with this syndrome require ICU care. But the good news is 98% of them survive. So they require very intensive care, but for all intents and purposes, they emerge just like with kids with COVID. They emerge. The question, however, is what are the long-term effects? given how many of their organ systems are impacted. The question is, what is the long-term impact? You mentioned heart. 80% of the children have cardiovascular impact. And so Dr. Jane Newberger is working with the Pediatric Heart Network to do long-term follow-up of these kids. How many of them are going to have lasting impact? There's a connection potential with Kawasaki disease. She's an expert in that. And the question is this something that's not necessarily Kawasaki, but something similar? Dr. Adrienne Randolph is running one of the largest CDC studies called Overcoming COVID-19. It was originally intended to look at the impact of COVID on children broadly, why some are spared, why some get more complications, why some get much sicker. But a subcomponent of that is going to be a deep dive into this MISC to understand why some children actually end up with this challenge. It's a very small number. We've seen just under 40 here at Children's, where we've seen 170 kids with COVID. So a very small part, and we're probably seeing the majority of the very sick COVID kids, MISC kids. Across the country, it's in pockets. Again, the children's hospitals are seeing relatively small numbers. DC Children's has seen a few more than us. Most of them are seeing just a handful. So it's a very small incidence, but something that I think parents need to be on the lookout for. And we will know more as we go deeper and study this.
So you mentioned an interesting number. You've seen 170 children with COVID in Children's Hospital.
Correct.
So that is kids who have had cases serious enough that they required hospitalization, or does that count kids who came in for some sort of routine screening and were tested just sort of incidentally, and it turned out they had it, perhaps an asymptomatic case?
It's both.
Well, that's a remarkably low number, right?
It is.
If
Compared
we look at,
to what the adults have seen. You're right.
if we look at Massachusetts, where the prevalence is, it's hard to know because of testing, but it could be that 10% of the state has had this, just judging by the deaths and the case numbers. 170 kids when 10% of the state has had this, that's remarkable.
That's correct.
So it leads to the next portion of what we wanted to talk about, which is that the predominant effect here, if we were to take a step back on how COVID-19 is affecting kids, is on their mental and social well-being. And everything from being isolated during quarantine, social distancing. What are you seeing about that? What are you seeing with that? And what are some of the best practices that are emerging, for families to deal with that? Of course, later we'll talk about what that means for the fall. But just, you work with children, you guys are experts on children. What basically are you seeing?
So I think everyone is increasingly concerned about both the direct and the indirect impact on children, not just their health, but their mental health, their behavioral health, their social and emotional health. You mentioned so many of the factors that I think are potential contributors to that. Isolation, fear, anxiety, stress in the home, potential violence, anxiety that these children are feeling in many ways. We're seeing this concern really spread across the country. So my colleagues at other children's hospitals have all said this is something that they're on the real lookout for. There's been a question about what can we learn from other wartime, other pandemics, and frankly there hasn't been an enormous amount of work in that area. Our colleagues here in psychology, in developmental pediatrics, in psychiatry, are all quite concerned about the impact because of the depth, the uncertainty, and the length of time of this particular pandemic. Children are, for the most part, resilient, probably even more resilient than many adults. And so if they've been in a supportive environment where there's been a lot of discussion, where parents have been comfortable talking about this, where they've explained the why, of the masking and the social distancing, And when there's been some stability in the home, and maybe even some real education going on in the home, I think that people are less concerned. Clearly, where we're concerned are where it's the opposite, where there is insecurity around even food and housing, where there is insecurity about safety, where parents are exhibiting more of their own stress and anxiety, where children are not being told anything about this, but they just are listening to parents and others and the news talking about it. So those are all things that I think people are concerned about, and ways that we can begin to talk to children. We can address some of their fears. We can be careful of how we talk about it in front of them or what they overhear, because that's really many of the things that they will then absorb and be concerned about. Toward that end, Brian, I think I mentioned to you that the British Medical Journal is about to issue a new special edition with a whole compendium of studies that have been done probably from around the world around children and stress and trauma and the impact of that on children. This isn't an area that has had a lot of attention, but they're now seeking reports from literally all over to see if they could put it all together. And our chief of our developmental pediatrics research program, Dr. Charles Nelson, is going to be one of the major contributors. They've asked him if he's done a lot of work in orphanages. He's done work in children that have been under different kinds of stress and trauma. So I think there's something we'll hopefully be able to learn from that. There's some good stuff on our website, which I think will be issued later, on what kinds of things to talk to children about, how to address all of these questions. Scary talks about COVID, tips for parents, and they've been put together in a form that really I think is easy for, sort of cartooned in a way that for very young children you can talk to kids, and then as they age and you need to talk to teenagers and young adults. So there might be some good resources there that people can go to.
So I think you and I both agree we want to be epistemologically and epidemiologically humble and not try to prescribe, should schools reopen, should daycare reopen? The answer to that is really complex. It depends on a lot of factors. That said, I was wondering if we could, without prescribing, pronouncing a verdict on that, we can combine what we've just been talking about and help inform the discussions that are going to go on around schools and daycare. And as people try to think about what the fall looks like, for example. So we've talked already about how kids, fortunately, seem to get the virus at a much lower rate. And perhaps it's because they have fewer of the receptors in their cells that the virus latches onto. So there would be a good explanation for why it's the case. And we also know, correct me if I'm wrong, that kids who get the virus seem to have, they're much more likely to have an asymptomatic or a very mild case. That is, even if they do catch it, right, than an adult. The other factor that's on people's minds, though, is whether kids who get the virus and may be unaffected, how much they're transmitting it. It also appears that they're transmitting it at a much lower rate than asymptomatic and mild adults are transmitting it to each other. So I was just wondering if you could update us on the state of what's known about that. So kids are not exactly known for having great hygiene, but could it be that with all the factors, they still are much less dangerous as vectors of this virus? And how should that inform how the fall and winter look?
So I think that the wisdom, at least for the beginning of the months of this pandemic here, that children were low transmitters. And that was true when we looked at the whole age spectrum from 0 to 19, for instance. There's a study that literally just was published from South Korea, which is the largest study, 65,000 people, and schools that have been reopened. And now they have basically come out, and people are looking very closely at the study. They think it is a very well done study, where they then took the children and broke them literally into two groups, 0 to 10 and 10 to 19. What they found is 0 to 10 children still look like they are very low transmitters. I don't think we know why. There's a, is their viral load that they carry lower than older kids because they're smaller and they carry less? Are they lower to the ground and therefore their droplets, don't reach up to us as adults? So there's a lot of theories about whether, why. But then they found that the 10 to 19s are beginning to look more like adults as transmitters. And so that's a study I think you have to go deeper on to understand, is that true? Is it just like adults? Are they just a little bit more than the younger kids? Because that obviously does have implications for the good news on the 0 to 10 for daycare, for preschool, for elementary school, but it may have different kinds of implications for kids over 10. And that's the upper elementary and into high school. So I think that's a piece of data that we need a lot more understanding of. One of the things we do know, and one of the things that we live our lives by these days, is watching the data and understanding the science. The science that, people will say it is really important for us to get these kids back into some form of routine in schools. And it is very important for not just their educational development, but every aspect that we already talked about, their emotional, social well-being. We also need to be watching the data as to how we make decisions about how schools should open, when they should open. Because one of the things we do know is how this virus is transmitted, and we know how to prevent the spread of it. So taking those two pieces, we should move forward, but we should move forward with science and data, is really how we should think about moving forward in the fall.
Is there any aspect of child psychology that should inform an approach to a tentative return to school? Like, for example, would it be worse potentially for kids to start up and then have to pull back? Would it be better to start, perhaps, maybe depending on the age group, it's different, with a plan that has a sort of conservative approach to the virus baked in and is maybe more likely to stay? Again, I know this all depends on the viral prevalence in any given community, but I asked this because a couple readers submitted this very thing as a question, like, what is it almost worse to start and have to pull back, or, any thoughts on that?
I don't think we know perfectly that answer, because we're facing the same set of issues in the healthcare world too, and probably in all our businesses, right? We need to open. We need to get kids back into care. We need to, not delay our surgeries any longer and our interventions on children. So we know we need to re-enter, and we enter, but the most important thing we need to do is to re-enter safely. What we know about this virus is that we want to control the infection rate and the spread. And so what we want to do more than anything is to think about how to open these schools safely. How to keep it safe for the kids? How do we keep it safe for the teachers and ultimately the family, the extended families? Education is important, and I think we've learned a little bit about virtual education, and that it works for some and it doesn't work for others. The kids, I hear all the time, they just want to be, in environments with other children, and so the most important thing we need to do is figure out what's the best, safest plan to reopen. Whether we reopen fully with all kids in, whether it's some kind of hybrid, and that has been sort of the preferred goal, is to do one of those two. Clearly, there are places that may want to do remote only, and if the infection rate is high, that is the safest thing to do. So if we watch the infection rate, and then we look at one of those other two plans of bringing children together, as long as we have a very vigilant, a very thoughtful plan, and I've heard, for instance, the plan in the Boston Public Schools with Brenda Cassellius, I was absolutely amazed at the level of thought and detail and planning, everything from the classrooms, the use of every space, the distancing that they're planning, transportation, kids with special needs, masking, hand washing, cleaning, All of those things. We've opened up our own daycare center, for instance. All of those things were absolutely critical to have in place, followed, no backsliding, and then a vigilance and a watchful eye for anything that might emerge. So I think those are the things we need to think about as we proceed.
Yeah, this data point that you mentioned, that in this emerging understanding about the difference in how kids 10 and younger are affected and how they transmit versus kids 10 and older, 10 to 19, that's fascinating. It seems like that's going to be something really to watch, because around 10 is really where you also, I think, the applicability of online learning, let's say, goes way up after age 10. And so I can just imagine someone watching this thinking, okay, online kindergarten is sort of problematic to imagine, right? But the risk reward trade-off is different for a 5-year-old than for a 12-year-old. So this kind of research is crucial to watch, it sounds like.
And, those older children, I mean, not everyone, because, some of us as adults aren't very good about our own behaviors, but, after age 10, I mean, you can hopefully, be more comfortable with a mask on for a period of time. Hand washing, surface attention, touching your faces, all of those kinds of things. And even a little bit of understanding of why social distancing, you can be together, but you got to be a little bit apart. And those are easier to do in an older child.
Before we get into live Q&A, I wanted to ask you just about 2 more things. You mentioned this idea of social distancing. I asked you about the question of a social bubble. And, some readers have asked about this as well. So, the idea that after if we've been fortunate enough to, not have to go to work and expose ourselves, a lot of us have been essentially not, having very little contact with a lot of people. And a lot of people have made this decision to open up the bubble just a little bit, let maybe just 1 or 2 other families in and socialize just with that group, maybe go rent a house together or something like that. A lot of readers asked, is that okay? And, I'm just curious what you would advise on that.
Well, not being a clinician myself, I think this is clearly a family decision. Who you can really trust to come into your circle that is really behaving and taking all of the precautions to protect themselves and whoever comes into the bubble. So when they leave the bubble, are they behaving? Are they not getting into the other different kind of risky behaviors of exposing themselves? Are they masking? Are they washing their hands? Are they keeping their homes and their all other surfaces clean? If they're doing all those things, they're lowering their own risk. And so when everybody comes into a circle that is lowering their own risk outside the system, outside the bubble, then I think you have some degree of comfort that inside the circle you're not exposing yourself and you're not putting yourself at risk. So it's a judgment that I think people have to begin to make, because this is going to be with us for a while. I know my own granddaughter kept saying to me, I just want to be with my friend Olivia. And so my daughter has opened her little, I didn't know it was called a bubble, but her own little bubble for my granddaughter. And, it has made the world of difference to her. She's 7. And, those are the things that families need to begin to think about, how they do it and do it safely.
The other thing I think you mentioned to me that I thought was important that we make sure we air is whether we're still seeing this phenomenon of people out of fear avoiding the doctor's office.
Mm-hmm, mm-hmm.
And I know you have a message on that you wanted to share. So, is it safe to take your kid to the pediatrician for the kind of routine care that we've come to, expect that they need?
So I think we really, truly want to assure everyone that all of our healthcare providers are taking every precaution they can to make this the safest environment for return to primary care physicians, to specialists, to hospitals, to health centers. It is absolutely everyone's North Star. And so we want to make sure that if children have symptoms of what could be COVID, fever, cough, sore throat, shortness of breath, nausea, vomiting, any of those things, they should call their pediatrician, at least call them, and if necessary, go in. We want to make sure that kids are continuing to get their regular care, their well child care, because it is critical that they continue with their immunizations. The last thing we need is another outbreak of something that we could have avoided. And please get your flu vaccine, because flu on top of COVID or the other way around, especially in children, will not be a good idea. We need to be, I think there are opportunities for, as you mentioned, Brian, safe social interactions, and being assured that children are getting off their devices. It'll improve the isolation issue. Exercise and outdoors are going to be really important for kids to get out after we have been somewhat cooped up in the spring and the winter. Having hard conversations with children about some of these issues, and being comfortable with them, I think, is another important thing. And then being vigilant about signs of depression, anxiety. And if you see any of those, kids not eating, kids not sleeping, kids talking about being worried about their future, unfortunately, self-harm, any of those things, or even talk about that, are things that you really need to think about accessing a professional. So there's a lot of things that we can do very positively and very proactively as parents and as caregivers of our children. And so just want to reinforce that.
All right, well, this will be a good time, I think, to bring my colleague Marjorie Pritchard on. And she has been, hello, Marjorie, good to see you. Marjorie has been going through the questions we've been getting during this talk. So
yes, we've had several questions, many of which focused on schools, to no surprise. And while we aren't going to say whether they should or shouldn't, people do want to know what's going to be happening in the classroom. So the first question is, what advice would you give to the parents of children with special needs whose education plans require social supports or aids while adhering to social distancing guidelines?
So there's a lot of, I think every school and school district is going to have to come up with their own plans. Clearly there are plans in place today for children with special needs, but now they have on top of that these extra requirements. Some children need more physical attention. Some are going to have even harder times because of what they've either heard or been through and are now coming in, fear of potential teachers wearing masks, all of those kinds of things. So clearly there has to be special attention for children with special needs. On our website, there is I think a pretty good, I looked at it myself, education for children with special needs, and a lot of tips for both educators and parents. One of the things that we're also doing is developing a summer series through our program called Children's Hospital Neighborhood Partnership. And this is going to be available to all educators across the state so that they can prepare themselves for how to deal with what is going to be a whole different environment. Different responses from children, different responses from parents, and this will help them both enter academically, but also social and emotionally with children. So hopefully those will do something to prepare educators, teachers, guidance counselors, and other support people in the schools. But also I think there'll be more that we will continue to put out as supports and helps specifically to parents as they prepare their children to go back to school.
That would be very helpful. Another question I want to know, are students in Black and Brown communities more likely to be infected since there is a higher rate of the disease in those communities?
So that's an important question that is even broader than COVID and this virus. One of the things that we have to do as a society is truly understand these communities, whether they are Black or brown or poor or have other social issues like lack of access to food, insecurity around housing, financial challenges, poverty. many of those children are disproportionately impacted by disease, by infections, and as we mentioned, mental and behavioral issues. We need to really do something so much better on the equity of care, access, ability to really understand how all of these things impact children. At Boston Children's, we have about 100,000 Medicaid kids in our group. And one of the most important things we're trying to understand is how to screen for these kinds of things that impact not just this virus today, but how does it impact both their acute illnesses as well as the management, the identification and management of their chronic illnesses. And so you're absolutely right. We do have a subset of our population that is not getting access or care or support for their child or their child's healthcare needs, and we've got to address that broadly. And that goes way beyond COVID.
Yes, it does. You spoke a little bit about the bubble, and that's with children of the same age, but grandparents are wondering whether they can reunite with their grandchildren.
There's a risk for sure. We saw our grandkids for the first time on Sunday since February, and I got to tell you, for 2 hours it was the happiest day of our lives. But we did it outside. We did it safely. I knew we were okay, and they made it clear that they had been within their house bubble and their social bubble. They were safe. And so I think we have to be very mindful. Masking, hand washing, if there's really truly vulnerable grandparents, I think they have to weigh the potential risk if these kids have been exposed in any way in their environments to what it might mean for them. So this is going to be a while until we get a vaccine. And so, as I know, we all want to go on living. We all want, no more uncertainty. We don't want change anymore. But unfortunately, I think for a while we're here with some of these precautions that have to be taken very, very seriously.
Andy, if I could just interject there for 1 second before we come back, Marjorie. Vaccine, there are no vaccine trials on anyone younger than 18, right?
Not at the moment, no.
So once there is a vaccine, it could be a while before it's considered broadly safe and wise to give vaccine to kids. That complicates how long this could go on, right?
Yes, it's always been the case. Children, most everything starts in adults in clinical trials. And once it's determined to be safe, then it moves to children. So children have always been a little bit at the end of everything, drugs and devices and everything else. And there's no difference here. Clearly everything is speeding up. And so will there be a faster turnaround than in the past to the way we would apply this to children? Most likely, yes. But will it lag a little bit? Most likely, yes.
Okay. And again, one more classroom question. How do you see social distancing occurring in a preschool classroom? Children like to play together and share materials. We can't keep them 6 feet apart and they won't wear their masks all day long. What can we do to help their social and emotional development while keeping them safe?
So we've been working with both the commission here on early education and childcare, as well as our own childcare center here that has a preschool component to it, to prepare for how to take care of children from infants all the way through to preschoolers. We will learn a lot from this as we also think about the schools, because they are now opening over a period of time. And some have been open now as emergency centers for a while, so we're learning from them. Interestingly enough, preschoolers are actually pretty good at wearing their masks. At least that's been our experience. They need breaks, and they need to be able to say, oops, did I just go off?
Yes, happens to everybody on every Zoom call.
Oops, sorry. They need breaks, and we have to figure out how to give them breaks and give them the opportunity with some ability to socially distance and do an activity or do something. But what we're finding is kids can wear masks and you can put them a little bit closer together. We're for most part not allowing adults into the classroom. We're cleaning and cleaning and cleaning and hand washing and hand washing and hand washing, and all of our teachers are wearing masks. So we're going through, I keep going back to the same theme I think you hear over and over again, that if we follow the appropriate vigilance and safety procedures and risk reduction procedures, we will provide an environment that is less risky, and we can kind of give kids little breaks so that we can do things in a classroom where we sit them 6 feet apart. We can give them materials and toys and other things to work on, but we also have to clean them a million times. So there's many different ways we're going to have to change the way we do things to improve the education and the social experience, at the same time keep them safe.
That's great. Well, back to you. This has been fascinating, and it's been quite helpful for both educators and parents, so thank you.
Thank you.
As you were answering that last question, Sandy, I couldn't help but wonder if the opportunity for outdoor education, outdoor daycare, and so on is an underappreciated. It's not obviously possible in all places and all circumstances, but if the potential for outdoor classrooms or other, at least here in New England, for a few months,
yeah.
If that's being baked into what's possible.
Yeah, I think that's absolutely true. We are allowing, we have playgrounds. We got to disinfect the playgrounds, obviously, between uses. The kids come in, they wash their hands. And so there are ways, both on the child care, the preschool, as well as we move into the school settings, to use outdoors as much as possible. Obviously, the weather here isn't great for us to do it too long into the winter. But I think there's opportunities to do more of that. And it's hot now. Unfortunately, it'll get cold later, and rain doesn't help. But I think we should be thinking about all creative ways to use every kind of facility that we have at our disposal. And I think that's how many of the schools are thinking about this. How do they use gymnasiums? Maybe not the way they used to use them, but use them for other purposes. Small classrooms, large classrooms, offices, every way we can think of reusing, and we're doing that same in the hospital, reusing what we have to get creative about.
So last question for you. You alluded to this a little earlier, but I want to come back to this question of how much you and your team at Children's are in touch with your peers around the world at other pediatric research and medical centers. I was wondering what's the latest you're hearing from South Korea, from China, from Italy, or so on. You mentioned Israel when we spoke the other day, on anything on what to do or what not to do. What's like the leading edge of international discussion about what is seeming to be wise?
So it's a great question. I think there's been some really good experience in the Scandinavian countries, Norway, Denmark, Finland, where they have both contained the virus, they kept the infection rate low, and they've gone back to schools. And they have been very mindful and very thoughtful about how they're doing that. Other places like Israel and South Korea and France have gone back to school, less vigilance, less risk reduction efforts, and they've had to open and close sporadically, and not, where they're not seeing these massive incidents of infection. But they've been mindful, and when they do, they shut down just to slow the spread. So although they've had to go up and down, it's been pockets, and they have addressed the pockets, and then they've been able to go back into a normal setting. So that's what we've learned a little bit about schools. Most of the places around the world have been able to open up their clinical, their primary care, their hospitals, and the like. And again, we're learning a lot about how carefully they have done that with safety as their principal issue that they're trying to continue to focus on. So From a research perspective, there's been more collaboration internationally than ever, both on care, this MISC, and because the numbers are so small, there's been a lot of collaboration, learning about how to treat, how to think about the long-term impact. There's been collaborations about understanding the impact of the virus physically on children and how to treat. Are there different kinds of drugs and treatments, as well as how we think about the mental and health, emotional well-being of children. So it's been a wonderful opportunity, I think, for both local, both in Boston and Massachusetts in this country, as well as international.
Well, Sandy, thank you. We're out of time. Thank you for being with us today. Thanks to Marjorie for moderating the questions. Just really appreciate your expertise and your wisdom. And thanks to everybody who joined us for this Op Talk. And we at Global Opinion hope you'll come back for the next one, which is at noon tomorrow, which is when my colleague Marcela Garcia will be talking with the presidents of 2 local community colleges about how they're dealing with the pandemic and the economic fallout. So thank you, everybody.
Thank you.